In this video, we'll discuss 3 disorders with ventilation perfusion mismatch. One with ventilation abnormalities, the other one with perfusion or blood supply abnormalities, and the third one with the disorders with a systemic abnormality. One with ventilation abnormalities is COPD, the second one is the pulmonary embolism, and the third one is the septic shock. Gas exchange is critically dependent on proper matching of ventilation and perfusion. If ventilation stops, the VQ ratio goes down to 0, and if perfusion or blood supply stops, then VQ ratio becomes infinite. Alteration in VQ ratio causes hypoxemia. Because of a higher ventilation at apices, blood coming from there has higher oxygen and lower carbon dioxide compared to the one coming from the bases. What's the effect of ventilation on PO2 and PCO2? When patient hyperventilates, PCO2 decreases and PO2 increases. When ventilation increases, carbon dioxide decreases. When PO2 increases, carbon dioxide decreases. PCO2 is directly proportional to carbon dioxide produced and inversely proportional to the alveolar ventilation. Conversely, hypoventilation causes increase in PCO2 accompanied by decrease in alveolar and arterial PO2. What's alveolar arterial oxygen gradient? It's the difference between the alveolar and arterial PO2. The alveolar PO2 is normally 100 and arterial also 100, but in certain circumstances it goes down to 85 millimeters of mercury, so the difference is 15. But with increasing age, it may go to as high as 30 millimeters of mercury. So VQ ratio in COPD. The VQ ratio in COPD depends on obstruction or destruction of the alveoli, which occur in emphysema. If small bronchioles obstructed, alveoli are unventilated, so VQ becomes 0. And when VQ becomes 0, nitrogen washout is delayed due to poorly ventilated areas. If alveolar destruction occurs as in emphysema, there is loss of blood vessel and ventilation both. On what stage of COPD PO2 decreases and PCO2 increases? PO2 usually remains near normal until FeV1 is reduced to less than 50%, and PCO2 remains normal until FeV1 is reduced to less than 25%. So PO2 normal until FeV1 is reduced to less than 50%, and PCO2 is normal until FeV1 is reduced to less than 25%. So VQ mismatch in pulmonary embolism. There is an increase in pulmonary arterial pressure in pulmonary embolism. Why there is increase in pulmonary arterial pressure? Increase in pulmonary arterial pressure in pulmonary embolism is because of increased sympathetic activity and vasoconstriction, and tachypnea is due to increased vagal activity. So what type of VQ mismatch occur in pulmonary embolism? There is no perfusion, so VQ mismatch in PE is dead space, so infinite. Patient normally hyperventilates, so there is hypocapnia, but rarely carbon dioxide retention occurs in pulmonary embolism. And number 2, local bronchospasm due to pulmonary embolism can also cause hypoxemia. So what are the positive tests in pulmonary embolism? D-dimer is increased, but D-dimer is also increased in DVT, MI, pneumonia, sepsis, and third trimester of pregnancy. CT chest with intravenous contrast is the principal imaging test for the diagnosis of pulmonary embolism. Now, VQ mismatch in septic shock. What happens to PO2 and PCO2 in septic shock? Both PO2 and PCO2 decrease in septic shock. There is an early fall in PO2 producing hypoxemia. And why there is low PCO2? Low PCO2 is due to tachypnea. There is increased pulmonary capillary permeability in pulmonary embolism that causes edema. Normally, the lung remains dry. Why normally the lungs remain dry? The pulmonary capillary pressure is 10 millimeters of mercury and plasma oncotic pressure is 25 millimeters of mercury. The plasma oncotic pressure tries to keep the fluid in the blood vessel, and the pulmonary capillary pressure or hydrostatic pressure tries to pull it out of the capillaries into the interstitial space. When pulmonary capillary pressure, which is normally 10 millimeters of mercury, goes up to 25 millimeters of mercury, it causes pulmonary edema. So increased capillary permeability results in increased pulmonary circulation and edema, which increases pulmonary capillary wedge pressure, decreases pulmonary compliance, and interferes with the oxygen exchange, leading to hypoxemia. 50% of these patients develop ARDS.